Hi guys, so I hope you have gone through the neuro revision video and now we will start with the cardiology. Of course, you know the important topics from cardiology. You are anticipating one question which is bridging between medicine and physiology, which is usually from heart sounds or the splitting of second heart sound or sometimes related to JVP. After that, the other important topics are myocardial infarction and ischemic heart disease, heart failure, valvular heart diseases, and pericardial diseases. One question on pericardial diseases is almost always anticipated, right? So when it comes to heart sound, the key points that you need to remember first is related to first heart sound. When it comes to first heart sound, the question they will ask is where do you get loud S1 and where do you get soft S1. So when it comes to loud S1, remember loud S1 you can get when there is hyperdynamic circulation. You can get loud S1 in hyperdynamic circulation. Then apart from hyperdynamic circulation, you also get loud S1 in mitral stenosis and tricuspid stenosis. MS and TS you can have loud S1. For exam, MS is particularly important. And then third, they may ask you the relationship between the loudness of first heart sound and the PR interval. Remember the PR interval, exactly speaking, the PR segment is the time available for the mitral and tricuspid valve to close. Shorter it is, the valves close in short span of time, they make louder noise, and longer it is, the valve have more time to close, so they make softer noise. So PR interval, which one should I write here for loud S1? Short PR interval or long PR interval? Of course, short PR interval. Short PR interval is associated with loud S1. And then when it comes to soft S1, you get that in patients with mitral regurgitation and tricuspid regurgitation. Exactly opposite of MS and TS. Because in mitral regurgitation, mitral valve is not closing, only tricuspid closing. In TR, only tricuspid valve is closing, mitral is not closing. Then second, when you have prolonged PR interval, abundant time is available for the mitral valve or the tricuspid valve to close, and because of that they don't make much noise. So you already remember the relationship between the loudness of S1 and PR interval. They are inversely correlated. Okay, after the loudness of S1 and S2, next is the questions will be on the splitting of second heart sound. Splitting of second heart sound. And when it comes to splitting of second heart sound, of course a lot of questions can be asked, but the important points that I want to reiterate right now that I don't want you to forget are: number one, where you get the so-called fixed split, usually also written as wide and fixed split. Wide and fixed split. You know the answer? Yes, it is seen in atrial septal defect. The second important point from the splitting of second heart sound is where do you get paradoxical split? Where do you get paradoxical split? The paradoxical split refers to, remember, the physiological split is inspiration only split, means the split is heard in inspiration, barely heard in expiration. And you know the mechanism behind that, because the right side of the heart gets more blood flow during the inspiration, the closure of pulmonic valve gets delayed. So you know that there is an A2 and P2. During inspiration, P2 gets delayed, making the split become wide. But if the split gets switched and it becomes evident in expiration, we call it as paradoxical split. Split heard in expiration is called as paradoxical split. Image-based questions are possible, so please go through the images that we have created during the offline classes. Where do we get it? There are two conditions where we can get the paradoxical split of the second heart sound. The first one is when there is severe aortic stenosis. Remember, in mild to moderate aortic stenosis, you get narrow split. It becomes paradoxical when it is severe aortic stenosis. Second one is left bundle branch block. In left bundle branch block, the wave of depolarization first goes to the right ventricle, causes its depolarization, and then comes to the left. That's why it gets delayed. And in case of the severe aortic stenosis, the aortic valve opening is so narrow that the left ventricle takes more time than the right ventricle to complete its ejection. That's why pulmonic valve closes first and then aortic closes. So you get this paradoxical splitting of the second heart sound, right? So these are the important points with respect to splitting of the second heart sound. I definitely want you to note that the physiological split is inspirational split. Physiological split is heard in inspiration. Heard in inspiration. And of course, you know from the main notes that anything that causes early A2 or late P2. See, you know that there is A2 and P2. Anything that causes early A2 or late P2 causes wide split. Anything that causes late E2 or early P2 causes narrow split, right? Okay. After the key takes on the splitting of second heart zone, now let us get into the important forms of pulse. Again, important questions are asked from the pulse. So we'll understand what points you need to know about the pulse. So the second major topic that we're discussing is pulse. What questions are usually asked from pulse? The first kind of questions are mainly the questions are going to be about abnormal pulse. The normal pulse, as you know, normal pulse is called as catacrotic pulse. It is called as catacrotic pulse. Then they will ask you, where do you get this pulsus parvus? Pulsus parvus means, you know, it's a small volume pulse. The stroke volume, whenever it is less, the pulse peak or amplitude becomes small. So small peak or small volume pulse or small amplitude pulse is what we call as pulsus parvus, right? So it is seen in any condition with low cardiac output or low stroke volume, any condition with decreased stroke volume. And the same pulsus parvus, if it is occurring in a patient with mild to moderate aortic stenosis, then we call it as anacrotic pulse. So what is anacrotic pulse? Again, it is nothing but a pulsus parvus seen in patients with mild to moderate aortic stenosis. We call it as anacrotic pulse. Same anacrotic pulse or same pulsus parvus, if it makes me feel the diastolic peak also, then we call it as dicrotic pulse. Dicrotic pulse. Where is it seen? It is seen in, again, any condition with decreased stroke volume. The key point to note about dicrotic pulse is you have two peaks felt. Normally we feel only the systolic peak, we don't feel the diastolic peak, but here we feel the two peaks, one in systole, that's the normal systolic peak, and one in diastole, which is normally not felt, but because of very low systolic peak, we start noticing the diastolic peak as well. That is what we call as dicrotic pulse. It is a form of pulsus parvus itself. Okay, then they will ask you, where do you get this pulsus et tardus? What is the meaning of pulsus et tardus? Tardus means slow. So when the peak appears late, late peak is equal to pulsus et tardus. This is classically seen in patients with left bundle branch block, because the wave of deep elevation first goes to the right and then comes to the left. So you get this late peaking pulse. But then there is another form of pulse called as pulsus parvus. Amplitude is small and the peak is also late. Pulsus parvus et tardus. Small amplitude and the peak appears late. This is seen in severe aortic stenosis, and you know that this is a marker of severity. If you encounter pulsus parvus et tardus in any patient, it means it is having severe aortic stenosis. So from the pulse, this is the most important question. Okay, then another question that you may get is pulsus bispherians. What bis means? Bis means two, and when you have two peaks in the pulse but both are felt in systole itself, then we call it as pulsus bispherians. So here we feel two peaks both in systole, then it is pulsus bispherians. One felt in systole, one felt in diastole is dicrotic pulse. Both felt in systole is pulsus bispherians. The important conditions where you can see that, first thing that should come to your mind is hypertrophic obstructive cardiomyopathy or HOCM. Apart from that, AR and AR along with AS. Important one to remember, HOCM. Okay, that is pulsus bispherians. Another type of pulse where the pulse peak keeps alternatively increasing and decreasing, which we call as pulsus alternans. Called as pulsus alternans. We have a similar ECG finding called as electrical alternance, that is seen in patients with massive pericardial effusion cardiac tamponade, not in patients with heart failure. This is seen in left ventricular failure, where you have alternating small and large peak pulses. Okay, so that's about the pulse. After the pulse, we will go to the JVP. The important points that you need to know from JVP are some abnormal waveforms. So the first question is, where do you get absent A wave? So you know that A wave is due to atrial contraction, which correlates with the active filling phase of cardiac cycle. It correlates with the P wave of the ECG. If it is absent, it means P waves are not there in the ECG, and classically where we get that? In patients with atrial fibrillation. So absent A wave indicates atrial fibrillation. Then tall A waves, which are also called as giant A waves or prominent A waves, they are seen whenever the right atrium faces an obstruction for the ejection of blood. Right atrium pushes the blood to right ventricle. If there's an obstruction, this obstruction could be because of tricuspid stenosis. It could be because of tricuspid stenosis. It could also be because of concentric right ventricular hypertrophy. It could also be because of pulmonary hypertension, because pulmonary hypertension leads to right ventricular hypertrophy, right? If you're finding it difficult to remember, just look at this. This is right atrium. Blood moves from right atrium to right ventricle, and from right ventricle to pulmonary artery. So if I have pulmonary hypertension, pressure in the pulmonary artery is high, then right ventricular afterload is increased because pulmonary artery pressure is already high. So when I want to eject the blood into the aorta, into the pulmonary artery, it is going to resist. Its pressure is high. I have to have higher pressure than this to push the blood. This is what we call as increased afterload. And if afterload increases, the muscles develop concentric hypertrophy. And if I develop concentric hypertrophy, pressure of this ventricle also becomes high because the volume decreased, pressure increased. Now to fill this ventricle, pressure in the right atrium has to become even higher. And when right atrial pressure increases, JVP increases, and the atrial wave of contraction is A, that becomes prominent. Okay. Apart from that, I can also have difficulty to fill this ventricle if it is collapsed. When does it collapse? In cardiac tamponade. Or if it is being restricted from relaxing, when I want to fill, it is not allowed to relax. In all those cases, right atrial pressure increases. So I can also have tall A wave in patients with cardiac tamponade and constrictive pericarditis. And constrictive pericarditis. Okay. And by default, whenever you have tall A wave, the X descent becomes prominent or steep. So you get steep X descent in any patient with any condition with tall A wave. So if A wave is tall, the X descent appears steep in any condition with tall A wave. Okay, so we are now done with A wave and the X descent. Next, what we have is the C wave and V wave. So with respect to C wave and V wave, the question they ask is, where do you get so-called fused CV wave, and where do you get prominent V wave? And when you say prominent V wave, we are almost referring to V taller than A wave. So if there is an image based question where they have marked the wave as V and it appears to be taller than A, it is not normal. Normally A is the tallest wave. So if V taller than A, that is prominent V wave. So both of them are seen in patients with tricuspid regurgitation. And remember, the fused CV wave is also known as Lancisi sign. It's called as Lancisi sign. Okay, next up we come down to what you call as Y descent. So with respect to Y descent, the questions mainly ask you to differentiate between cardiac tamponade and constrictive pericarditis based on Y descent. So remember, Y descent is absent because in cardiac tamponade passive filling is not possible. So you'll have an absent Y descent in cardiac tamponade. But what happens in constrictive pericarditis? In constrictive pericarditis, passive filling happens, but it gets abruptly cut short. And when abruptly we cut short the passive filling, what do we encounter? Y descent will be there, but the time available for the passive filling is shortened. It creates an impression or a perception of steep Y descent. So in cardiac tamponade, you have absent Y descent and you have steep or prominent Y descent in patients with constrictive pericarditis. So on this basis, you are anticipating questions. Consistently last 3 years, there had been questions asking you to differentiate between cardiac tamponade and constrictive pericarditis. In every question, Y descent was the theme. There are other possible differentiating features like the square root sign in patients with the constrictive pericarditis, then various other like Beck's triad, along with that the electrical alternance, muffled heart sound. There are pointers, but examiners have chosen to use Y descent as the key differentiating feature between tamponade and pericarditis in last 3 years. So I don't want you to miss this point. Okay. Now I also want you to note another important point, that JVP generally decreases during inspiration, because inspiration, negative interthoracic pressure, more blood goes to the right side of the heart. So JVP decreases during inspiration. If JVP fails to decrease during inspiration, if JVP, what do we call that sign as? If JVP does not decrease during inspiration, we call it as Kussmaul sign. It's called as Kussmaul sign. It's called as Kussmaul sign. And please remember, when the JVP fails to decrease in inspiration, if the right atrium is already loaded with blood and there is no space available for the right atrium to take more blood, then JVP will not decrease. This Kussmaul sign can be seen in various conditions. Can be seen in conditions with increased right atrial pressure. So where all we will have increased right atrial pressure? Yes, we can have it in constrictive pericarditis. You can also have it in patients with right ventricular MI. You can also have in patients with cor pulmonale, because already the right sided pressures are high. You can have it in patients with pulmonary hypertension. In severe case of tricuspid stenosis and tricuspid regurgitation also you can have it. But for some unknown reason, I'm telling you some unknown reason, so don't ask me, sir, explain the mechanism. The mechanisms are not very clear. Yeah, there are possible ways to explain it, but not required. It's not very clear. It's usually not seen in cardiac tamponade. So again, an important MCQ point, that Kussmaul sign is seen in any condition where there is right atrial pressure very high, but for some reason it is not seen in cardiac tamponade. In cardiac tamponade also, because the ventricle is not able to receive the blood, right atrial pressure will be high, but still you don't get to see Kussmaul sign. The JVP does decrease during inspiration in cardiac tamponade. So this is a very, very important MCQ point. So if examiners chooses to divert from the Y descent, I feel this is a point that they're going to latch on to. Clear? Okay. So this is about our JVP. Now after JVP, we will get into the pericardial diseases. Let us talk about the pericardial diseases. And when it comes to pericardial diseases, the first pericardial disease we're going to talk about is acute pericarditis. Acute pericarditis. Anything that duration of less than 6 weeks, we will call it as acute pericarditis. The most common cause for acute pericarditis, as you know, is idiopathic. Other than that, viruses, bacteria, fungi, they all can cause pericarditis, but the most common cause is idiopathic. Apart from that, you can have viruses as the leading cause, followed by bacterial. Fungi are extremely rare. But apart from that, you can also have autoimmune causes for acute pericarditis. Like you can see it in patients with SLE, rheumatoid arthritis and all. And remember, the most common cardiovascular manifestation of SLE is acute pericarditis. Most common cardiovascular manifestation of rheumatoid arthritis is acute pericarditis. Okay. Apart from that, you have one more autoimmune pericarditis, which typically happens after myocardial infarction, which is called as Dressler's syndrome. Usually 1 week after myocardial infarction, patient develop chest pain again, and this time it is not because of MI but because of acute pericarditis. Dressler syndrome refers to post-MI pericarditis. This is post-MI acute pericarditis. Other than that, high urea levels, uremia, and even trauma, directly penetrating injury to the chest, can also cause acute pericarditis. These are all causes. Now, what clinical features these patients present to us with? The patients with acute pericarditis present with chest pain, but this chest pain is little different from the pain of MI, but somewhat similar also. What is the similarity? This chest pain is retrosternal, just like the pain of ischemia. It's a retrosternal chest pain. But how is it different? This pain is sharp and penetrating type. And remember, the pain of MI is not sharp and penetrating. It is diffuse, squeezing, or constricting type. Patient cannot sharply localize where exactly it is hurting in a case of MI. But here it is sharp, penetrating type. And then it is worse on inspiration and also when he is lying down. The pain of MI or angina does not have any correlation with the position of the patient, right? So these are the symptoms they come to us with. And then on examination, what findings we get when we auscultate? Here there are two layers of pericardium, as you know, visceral and parietal. They are inflamed. They start rubbing against each other, and that rubbing produces a noise which we call it as simply pericardial rub, or you can also call it as pericardial friction rub. Pericardial rub or pericardial friction rub. So when I get this, for evaluation, we go ahead with the ECG. We can do echo as well as ECG, but ECG is the most convenient and preferred investigation. Right now, we can consider ECG as the investigation of choice over echocardiography. And when we do ECG, what findings we are going to get on the ECG? Unlike the MI, where only ST segment gets elevated, in patients with acute pericarditis, there is multiple segments getting affected. So first is, yes, you will get ST elevation, which is going to be concave, and this ST elevation is going to be affecting multiple leads, and this ST elevation does not have no reciprocal changes. Even the reciprocal leads will be showing ST elevation only, reciprocal changes. In case of MI, you will have reciprocal changes. Okay, then there will also be PR segment depression. PR segment depression. And third, you will have a down sloping TP segment. Means if this is the ECG that we are looking at, then what will happen in acute pericarditis? In acute pericarditis, the PR segment will go down, it gets depressed. The ST segment becomes concavely elevated. Okay, and then this is a T wave. So TP segment from here starts going down. This down sloping TP segment is what we call as spodic sign. So you will get down sloping TP segment, and we call it as spodic sign. This is spodic sign. So this is spodic sign. This is concave ST elevation, and this is PR depression. All the findings we are going to get in acute pericarditis. So once you get these findings, you know that it is a case of acute pericarditis. And when it comes to management, because majority of the patients are idiopathic, we don't know the cause, we will primarily follow symptomatic treatment. So what will be my symptomatic treatment? We will use a combination of NSAIDs plus colchicine. Colchicine is an anti-inflammatory drug, and studies have also shown that colchicine decreases recurrence rate to some extent. If you use it when the first time pericarditis happens, if you use colchicine, the chance of pericarditis recurring is less. if I try to get the control only with NSAIDs, first of all, I need high dose, side effect risk, bleeding risk, because NSAIDs inhibit platelet function, and the chance of recurrence after the recovery is high. So it decreases recurrence risk. The colchicine, apart from exerting anti-inflammatory properties, decreases recurrence risk. So if first line drugs fail, then we go for second line. In second line, we generally consider corticosteroids. And if there is frequent recurrence, remember, if there is frequent recurrence despite your thorough investigation, you're not able to find a cause and it keeps recurring, then what should I do? Then either you can use anakinra, or you can go for pericardiectomy, because frequent recurrence increases the risk of developing what we call as constrictive pericarditis, right? Frequent recurrence is associated with increased risk of constrictive pericarditis. So that's why you have to consider either putting the patient on anakinra or pericardiectomy. In India, people may not be able to afford anakinra and they may not be willing for surgery. In such cases, at least we give them colchicine to prevent the recurrence risk. So that is an added thing that you need to know from this revision video. Now let us talk about chronic constrictive pericarditis. So now when we talk about constrictive pericarditis, the key point I want you to remember is that constrictive pericarditis is usually because of, so when we're going to talk about constrictive pericarditis, the constrictive pericarditis is because either recurrent acute pericarditis has resulted in scarring of the pericardium, or you had chronic pericarditis like tuberculosis. These are the leading causes, right? So we are talking about constrictive pericarditis or chronic constrictive pericarditis. For this constrictive or the chronic constrictive pericarditis, the most common cause in India is tuberculosis. For the rest of the world, the most common cause in India is TB, tubercular pericarditis, and rest of the world, or you can say the developed world, it's going to be recurrent acute pericarditis. Recurrent acute pericarditis. Now, in both these cases, the point that should come to your mind is either recurrent acute pericarditis or TB pericarditis result in scarring of the pericardium. So there is scarring or stiffening of the pericardium. Scarring has resulted in stiffening of pericardium, and because of stiffening of pericardium, the pericardium can only stretch a little bit, and passive filling is only possible still the limit of stretch of the pericardium is reached. Stiffening of pericardium, and the stiffening of pericardium has resulted in abrupt cessation of passive filling. And remember, once I am not able to do full passive filling, normally how much we fill during passive filling? Almost 70% of filling happens in passive filling, around 20 to 30% happens in active filling. So if I abruptly cut, I may not be able to transfer the blood from the atria to ventricle full 70% that we generally do in passive filling. It may drop down to 60, 50, 40, 30 depending on the severity, right? Now in terms of clinical features, so please remember this again, the constrictive pericarditis affects RV filling more than left ventricular filling. So it's primarily a right heart disease, because you know the left ventricle is more muscular, left side of the heart is more muscular. So somehow filling may be done to some extent, but right gets affected. Okay. So now in terms of clinical features, these patients present with the classical symptoms of right heart disease. What are those? You will have raised JVP, and you know that when we have raised JVP, here you will have a tall A wave. Why tall A wave? Because the transfer of blood from right atrium to right ventricle that happens during active filling, the burden is more on active filling because we have done less passive filling. We had abruptly stopped passive filling, so less amount was done passive filling, so I have to do more active filling, so pressure increases. So I'll have tall A wave, and you know that whenever there is tall A wave, you get a steep or prominent X descent. Steep or prominent X descent. Now, because there is abrupt cessation of the passive filling is going on, so you will have the Y descent, but then abruptly you stop. And remember, go back to the workbook and see the image that we had created. We're reducing the time available for passive filling The top to bottom y descent comes in less time, and it creates a perception or an illusion of steep y descent. So you get steep y descent, and the steep y descent that we get in patients with constrictive pericarditis is called as Frederick's sign. It's called as Frederick's sign. While talking about JVP, I think I forgot to reiterate another important point. You can have some intermittent tall A waves. We call them as Canon A waves. Canon A waves refers to intermittent tall A waves. Intermittent tall A waves are called as Canon A waves, and they are seen in conditions with AV dissociation. Seen in conditions with AV dissociation. Intermittent tall A waves are called as Canon A waves. Again, a very important MCQ point. They are seen in any condition where atrial rate becomes more than ventricular or ventricular becomes more than atrial. That condition we call it as AV dissociation. And tell me now, when atrial rate will be more than ventricular and when ventricular rate will be more than atrial. So AV dissociation can happen in AV blocks, particularly complete heart block, which is also called as third degree AV block. Here what happens? You have a new pacemaker in the ventricle whose rate will be low, atrial rate will be higher. Apart from that, we can have atrial arrhythmias where like multifocal atrial tachycardia, focal atrial tachycardia, PSVT, all of them. You can have arrhythmias, atrial arrhythmias. Second, where ventricular rate will be more than atrial rate in patients with ventricular tachycardia and ventricular fibrillation. And these Canon A waves are visible on the neck because the JVP pulsation is visible. We call it as frog sign. Particularly, the frog sign word is usually described for patients with a type of atrial arrhythmia called as AVNRT. But we can generalize it and say that visible Canon A waves, we call it as frog sign. Right? So there are a few named signs to remember here, as you notice. Frog sign is visible Canon A waves. Then we had this Frederick sign that we are getting in patients with constrictive pericarditis. Is nothing but steep Y descent. Okay, these are the JVP findings we are going to get. Apart from that, right atrial pressure is high. So because of that, you can have hepatomegaly. You can have ascites and pedal edema, the typical right-sided symptoms. If the condition is severe, it may affect left also, but mostly it is a right heart disease. Now, when someone comes with the right heart symptoms, that is raised JVP, hepatomegaly, ascites, pedal edema, now you know that it could be constrictive pericarditis. It could also be cardiac tamponade. It could be right heart valve diseases like tricuspid stenosis, TR, PES, PR. How do we diagnose? Examination findings and investigation will take us to the diagnosis. So what examination findings we are getting? Yes, here we are getting some JVP changes which may not be seen or differently seen in other conditions. For example, if it is tricuspid regurgitation, then if there is tricuspid regurgitation, I will have tall A waves. Okay, by default I will have steep X descent, but in addition to that, I will have fused CV wave, which is called as a LAN-CC sign, or I may have prominent V wave taller than A wave. That will take me to the diagnosis, right? If I'm suspecting constrictive pericarditis, I will go ahead with investigation. And when it comes to investigations in constrictive pericarditis, the investigation of choice is right heart catheterization, right? Apart from that, you may do X-ray, and if you do X-ray, you may see a calcified rim of pericardium, but that is not diagnostic. It only says that the pericardium is calcified, rim of pericardium. What do we get on right heart catheterization? When abruptly we stop, like during isovolumetric relaxation, the right ventricular pressure is decreasing, right? Then during passive filling, the blood is filling the right ventricle, pressure starts increasing, but then abruptly we stop. And then the heart waits for the active filling to start and the blood starts filling, right? What do we call this wave? This is what we call as the square root sign, or the square root sign is also called as dip and plateau sign. Okay. So with that, once you confirm the diagnosis, When it comes to the management of constrictive pericarditis, if TB is the cause, we treat them with ATT, and if it is due to recurrent acute pericarditis, then what should I do? Pericardiectomy or pericardial stripping. If TB, we go ahead with ATT generally for 1 year, but if recurrent acute pericarditis is the cause, we go for pericardiectomy or pericardial stripping. That's about our constrictive pericarditis. What are the key points to remember? I forgot to mention examination findings. So on examination, when we examine these patients, the abrupt cessation of the ventricular filling makes the ventricle vibrate vigorously, and that produces a noise which we call as pericardial knock. Pericardial knock. Okay. Apart from that, when the pericardium is healing with fibrosis, it may develop adhesions with the fascia behind the intercostal muscles. And because there are adhesions between the pericardium and the fascia behind the intercostal muscles, whenever heart contracts during systole, it may pull the intercostal muscles inwards, right? Retraction of intercostal muscles during systole. What do we call it as? Broadbent sign. What is Broadbent sign? Intercostal muscle retraction, mainly 12th, 3rd ribs posteriorly during systole. We call it as Broadbent sign. Okay. Now let us talk about the cardiac tamponade. The next topic is cardiac tamponade. So what is cardiac tamponade? Massive pericardial effusion resulting in collapse of the right ventricle. So whenever you think of cardiac tamponade, you should think of massive pericardial effusion leading to collapse of right ventricle. Collapse of right ventricle. Okay. Now the most common cause is hemopericardium, and the most common cause for hemopericardium is trauma. Trauma is the most common cause for hemopericardium. Okay. Now in these patients, what clinical features we are expecting in a patient with cardiac tamponade? Yes, again, what we are talking about, collapse of right ventricle, right? And whenever there is collapse of right ventricle, the point to note, it is not easy to relax a collapsed right ventricle where there is so much fluid around it. So it results in no possibility of passive filling at all. So whatever filling we do into the right ventricle, it always has to be done with active filling. So in the constrictive pericarditis, the key differentiation is passive filling is there, but there is abrupt cessation of it. Here there is no passive filling at all. And now you know that the wave of passive filling is Y descent on JVP, it will be absent. And because it is affecting right side of the heart predominantly, you will have raised JVP, and the raised JVP will show a tall A wave because no passive filling. All the filling has to happen during active, so force generated is more, A wave becomes tall. And whenever A wave is tall, we will have a steep X descent. But because there is no passive filling, you will have absent Y descent. Absent Y descent. This is a very, very important point. Apart from that, cardiac tamponade also means that right ventricle is only filled actively, usually 70% passive, 30% active. Even if with extra effort, I may be able to take that 30% active to 40%. So the right ventricular output will become less because right ventricle has received less blood. So if RV output is less, LV filling is less, LV filling is less, LV output is less, and that results in, you know that the systolic BP is directly proportionate to stroke volume. So if LV stroke volume is less, the systolic BP will be less. So we will end up with hypotension. And when you auscultate, you will also notice that fluid is not a good conductor of sound, so heart sounds are not heard clearly. You will have muffled heart sounds. Muffled heart sounds. Muffled heart sounds. And collectively you call it as Beck's triad. Okay. Apart from that, you may also have pulsus paradoxus. But you generally don't get what we call as Kussmaul sign. pulses paradoxus is seen, but usually no Kussmaul's sign. You get that Kussmaul sign in any other condition where right atrial pressure is high, but somehow it is not seen in cardiac tamponade. So once you're suspecting cardiac tamponade based on this, we will go into investigations. And when it comes to investigation, if you do ECG, what are the findings you are going to get? The fluid is not a good conductor of electricity. Means it is a good conductor of electricity, but the electricity diffuses through the fluid. Wherever fluid is, the electricity goes. So the amount of voltage reaching the electrodes becomes less. So you will have low QRS voltage. And you also know that anytime BP is low, sympathetic nervous system gets activated, so you can have sinus tachycardia. The third thing is, you may also end up with what is called as electrical alternance, alternating short and tall QRS complexes. Why is that happening? Because in that pericardial fluid, heart may keep moving like a pendulum. So sometimes it comes close to surface, sometimes away. So when it comes to close to surface, you will have tall QRS. When it goes away, you will have small QRS. We will call it as electrical alternance. Electrical alternance. This is due to pendular motion of heart inside the pericardial fluid. Pendular motion of heart inside pericardial fluid. So here you will have alternating small and large QRS complexes, what you call as electrical alternance. Okay, this is ECG findings. But if you do echo, echo is also called as point of care ultrasound if it is done bedside. The echo or POCUS, you get a triad. What is a triad? In this, you will have collapsed RV. That's the main requisite for the diagnosis of cardiac tamponade. And the RV is collapsed because of pericardial fluid. That pericardial fluid could be blood as well. And then the third thing is, you may also have a dilated inferior vena cava, because right atrial pressure is high, both the superior and inferior vena cava pressure increases. Superior vena cava pressure increase, it shows up on the JVP. Inferior vena cava pressure increase directly may not be visible to our naked eye. There's nothing visible on the body, but under the echocardiography we can see that. And in these patients, if you do a chest X-ray, the heart with the fluid generally because of gravity gets distributed at the bottom. So if I'm looking at the chest X-ray, because of the fluid distributed at the bottom because of the gravity, you will notice that heart takes the shape of a water bottle or money bag. Takes the shape of a desert people's water bottle or old generation people's cloth money bag, right? So we call it as water bottle or money bag heart. So we can get what we call as water bottle or money bag heart. But if they're asking what is the investigation of choice, echo or POCUS is the investigation of choice for diagnosis of cardiac tamponade. And once you're diagnosed as tamponade, the patient's hypotension will only improve if the collapsed right ventricle is made to reopen, start receiving blood and start ejecting the blood to the lungs so that it goes to the left side of the heart and left-sided stroke volume increases. And that's only possible if I draw the fluid out. And how will I draw it? Yes. So when it comes to management, the first step is usually emergency pericardiocentesis. Emergency pericardiocentesis. And the preferred route for this pericardiocentesis is going to be, what will be the preferred route? Yes, the preferred route is substernal or subxipoid. Substernal or subxipoid. That's the preferred route. After that, to make sure that there is no further accumulation of the pericardial fluid, because many times it is hemopericardium and patient may continue to bleed. So we need to keep draining that. So we might have to consider placing a pericardial drain. And pericardial drain only ensures that more fluid does not accumulate in the pericardial space. But whatever trauma which is causing the bleed, if the bleed continues, patient may die because of bleeding. So the third step after this if required, is to go ahead with surgical exploration. Try to identify where is the trauma, which blood vessel is bleeding, and then try to ligate it, cauterize it, whatever that needs to be done, do it. That's our last step, right? So that completes our pericardial diseases. Key point is, in case of cardiac tamponade, you have muffled heart sound and absent Y descent, and you don't have Kusumal sign. In case of constrictive pericarditis, you have Kusumal sign, you have a steep Y descent, and you have pericardial knock instead of muffled heart sound. Okay. Now let us talk about the next topic we're going to talk about is going to be our heart failure. And when we are talking about heart failure, the key things that are usually asked as an MCQ is EF based classification. So we classify heart failure into two broad groups based on the ejection fraction. So if the EF is less than 40%, we call it as heart failure with reduced ejection fraction, and heart failure with reduced ejection fraction is equal to systolic heart failure. Here the EF is low because of the force of contraction required to eject the blood is less. That's why the percentage of blood ejected has become less. So it is systolic heart failure. And if EF is more than or equal to 50%, we will call it as heart failure with preserved ejection fraction. Some books also call it as heart failure with normal ejection fraction. Fair enough, right? You know that normal ejection fraction is 60 to 70%, and it depends on the force of contraction of the ventricle. It can increase in physiological state, like when we are doing exercise, sympathetic nervous system activation increases the force of contraction of the ventricle and EF increase. That's how we get more cardiac output during physical activities. Okay, and here the problem is not in ejection, the problem is in filling. So we'll call this as diastolic heart failure. The most common cause for systolic heart failure is ischemic heart disease or MI. The most common cause for diastolic heart failure is hypertension, right? Apart from that, even the hypertrophic cardiomyopathy causes diastolic heart failure. So this is something that I want you to remember, because repeatedly they're asking question, what kind of cardiac dysfunction occurs in hypertrophic cardiomyopathy? Only when obstruction becomes, ejection gets affected. Till that time, it is concentric LVH. LVS becomes small, so filling that becomes difficult, so it's a diastolic failure. So hypertrophic cardiomyopathy causes diastolic dysfunction. Remember that point. Okay. Now that is about the classification. Then they will ask you about diagnosis. So diagnosis is primarily based on signs and symptoms of heart failure. Plus we need a marker. What is a marker? The biomarker is increased BNP or N-terminal pro-BNP. So this BNP or N-terminal pro-BNP are considered as the biomarkers of choice for diagnosis of heart failure. These are biomarkers of choice for diagnosis of heart failure. Got it? Now, if you diagnose a case as heart failure, when it comes to its management, there are a few points to note here. Remember, there is upregulation of RAS whenever there is heart failure, and there is also upregulation of the natriuretic peptides. Natriuretic peptides. And because natriuretic peptides make you excrete more sodium and water and reduce the preload, they are beneficial to a patient with heart failure. They are beneficial. But this increased activation of RAS plus sympathetic nervous system, RAS and sympathetic nervous system both are activated. These are harmful. These are harmful. Why are they harmful? Because the RAS causes vasoconstriction and increases the afterload, which is burden on the heart, which is already failing. Then RAS also increases aldosterone, increases sodium and water reabsorption, increases the preload, which is a burden on the heart, which is already failing. So these are harmful. So that's why we prefer to block RAS and sympathetic nervous system. So how will I block RAS? I can block RAS with AC inhibitors or ARBs. And I can also block RAS with the aldosterone can be blocked with spironolactone. How will I block the sympathetic nervous system? By giving the beta blockers, preferably the cardio selective beta blockers. And then this natriuretic peptides are beneficial. I want to facilitate it. How will I facilitate or increase its action? We know that natriuretic peptides are broken down by the neprilysin. So I can facilitate the action of natriuretic peptides by blocking neprilysin. And one neprilysin inhibitor that is right now available in India is sacubitril. And you guys already know that sacubitril is available in combination with valsartan, right? So if you are using this, we should consider knocking out the pre-existing AC inhibitor or ARB that patient is taking. So when it comes to the management, I will give you a simple protocol. If it is a heart failure, whatever we know right now actually comes from our experience of heart failure with reduced ejection fraction. Though we extrapolate this treatment to heart failure with preserved ejection fraction, we know less about it because studies are not there. We have a lot of decades of studies about heart failure with reduced ejection fraction. So what we do is we see if EF is less than 35%, or if EF is, of course, to call it as reduced ejection fraction, EF has to be less than 40%. And if it is between like 35 to 40%, you can say. If it is less than 35%, like let us say if it is more than 35%. So our treatment will comprise of an AC inhibitor or ARB plus a beta blocker plus spironolactone. And studies have shown that adding SGLT2 inhibitors have cardioprotective benefits. So we use them. And these are all known to reduce mortality. They decrease mortality. But if EF is less than 35, of course, we will be using these drugs, but that is not enough. I need to do more. What is that more I need to do? So when EF is less than 35%, instead of using AC inhibitor ARB, what we will do is we use a neprilysin inhibitor, and it comes with a combination of AC inhibitor or ARB like valsartan. So we will use a combination of angiotensin receptor blocker plus a neprilysin inhibitor, which we call as ARNI, which includes valsartan, which is an angiotensin receptor blocker, plus sacubitril, which is a neprilysin inhibitor. So first MCQ they may ask is, when is it indicated? Yes, it is indicated in heart failure with reduced ejection fraction, to be more precise, when EF is less than 35%. Along with ARNI, we will definitely consider adding the other drugs, beta blockers plus spironolactone plus SGLT2 inhibitors. Okay, so these are all standard treatments. So main thing that changed is we are not using AC inhibitor ARB alone. We are combining it with a neprilysin inhibitor. That is the first change if the ejection fraction is less than 35%. Okay. Second, you should also remember that the patients with ejection fraction less than 35% are at increased risk of death due to ventricular arrhythmias, VT or VFib. That's why these patients, we need to consider implantable cardioverter defibrillator, because they're at increased risk of developing VTVF. Lower the EF, higher the risk of VTVF. And if there is a combination of this EF less than 35% with the left bundle branch block, there is an asynchrony created, because if there is a LVBB, the wave of depolarization first goes to right. So right ventricle contracts first, and then it comes to left, and then left ventricle contracts, and this asynchrony worsens heart failure. So combination of LVBB with low EF is again a deadly combination. So I want to get that synchrony back. So if patient with EF less than 35% has LVBB, we have to consider cardiac resynchronization therapy, a form of pacemaker which helps you to achieve the ventricular synchronization which is lost. So in simple words, if EF is less than 35% with LVBB, that patient needs ICD plus CRT, right? So if the EF is less than 35%, but no LBBB, only ICD alone. But if less than 35% and LBBB also present, ICD is required to reduce VTVF risk, and CRT is required to get the synchrony back. Okay, so that's about the management of heart failure. They may again ask, all these are also associated with mortality benefits. They decrease mortality. Then where is the problem? Digoxin. Digoxin, if used for long term, it is associated with increased mortality. This is an again important MCQ point. If you use digoxin, it is only used for symptomatic improvement during acute worsening of heart failure or acute heart failure, not for the chronic management of heart failure, because it increases mortality. Okay. Then in terms of advanced treatment, they may ask what all is available for a patient with heart failure. So what do we have in terms of advanced treatment? In terms of advanced treatment, mainly we have number one, we have left ventricular assist device, where we connect a external pump which does the work of pumping the blood. LV's work is done by this assist device. Not a long-term solution. So if you want a long-term solution, you need to find a donor to get the cardiac transplantation done. Cardiac transplantation done. That's about our heart failure. Okay. So after heart failure, let us get into the cardiomyopathies. So what are cardiomyopathies? Cardiomyopathies are diseases of cardiac muscle in the absence of obstruction, hypertension, and valvular heart diseases and ischemia. None of these should be there. Then we call it as cardiomyopathy. And you know that cardiomyopathies are classified into three major subtypes. One of them is dilated cardiomyopathy. Second one is restrictive cardiomyopathy. And the third one is hypertrophic cardiomyopathy. Dilated cardiomyopathy is the most common clinically apparent cardiomyopathy, means symptomatic cardiomyopathy. Hypertrophic cardiomyopathy is overall most common, but these patients don't have symptoms, majority of them. That's why it's not usually diagnosed. Until and unless we screen the whole population, we may miss it. Okay. The most common cause for dilated cardiomyopathy right now is alcohol. Alcohol is the most common cause for it. Apart from alcohol, the drugs like the cancer chemotherapy drugs, trastuzumab, adriamycin, doxorubicin, these are all known to cause dilated cardiomyopathy. Okay, apart from that, familial, it can be inherited, and the most common mutation responsible for dilated cardiomyopathy is mutation in titin gene. This is an MCQ asked multiple times, so I want you to remember. Okay. Then all these patients, in terms of clinical features, they present with heart failure with reduced ejection fraction, and in terms of treatment, all we do is treat underlying cause. Like if it is drugs, withdraw the drugs. If it is alcohol, try to cause the addiction in the patient. And then standard treatment of heart failure, ACE inhibitors, ARBs. Based on the ejection fraction, you can choose whether ACE inhibitors are enough or I need to use ARNI and other drugs, SGLT2 inhibitors and all. Restrictive cardiomyopathy, always think of storage disorders, right? Most commonly due to storage disorders like hemochromatosis, amyloidosis, lipid storage disorders, glycogen storage disorders. Which all glycogen storage disorders cause cardiomyopathy? I leave it to the biochemistry sir to give you a list of it. For me, anything that is a storage disorders can cause restrictive cardiomyopathy. So here it affects right heart more than left. It affects right heart more than left. So basically these patients present with restrictive, means they present with right heart failure. So in terms of clinical features, they present with right heart failure, and in terms of treatment, it is like treating the underlying cause. If cause is not treatable, you can consider the transplantation. Hypertrophic cardiomyopathy, it is purely inherited. It is an inherited cardiomyopathy. It cannot be acquired, and it is most commonly due to mutation in beta myosin heavy chain gene. Beta myosin heavy chain gene. And it is very common, affecting 1 in 500 births. And because it's so common, screening is recommended. The investigation of choice for screening is echo. Now, exactly what happens in these patients? These patients develop concentric LVH and asymmetric septal hypertrophy. So basically what happens here? These patients, left ventricle, like let us say this is left side of the heart, this is left atrium and left ventricle, this is a normal left ventricle, this is the aortic valve, and the area where the blood leaves the left ventricle and goes towards aorta is called as left ventricular outflow tract. It is called as left ventricular outflow tract. What happens in the hypertrophic cardiomyopathy is you start developing the LVH concentric type, muscle is added inwards, but this interventricular septum becomes asymmetrically hypertrophied, and this asymmetric hypertrophy of the interventricular septum, asymmetric hypertrophy of interventricular septum starts creating eventually obstruction of the blood flow from left ventricle to aorta. When it starts creating obstruction, then we call it as hypertrophic obstructive cardiomyopathy. So this is what we call as ASH, or asymmetric septal hypertrophy. So this is asymmetric septal hypertrophy. Yes, you have concentric LVH, and because of that you may have a dynamic left ventricular outflow tract obstruction. Okay, so in these patients of hypertrophic cardiomyopathy, majority of them are asymptomatic. But once they develop the obstruction, if HOCM, they will have symptoms similar to aortic stenosis. That's why these patients are also called as subvalvular AS, subvalvular aortic stenosis. Okay, and these patients are at increased risk of sudden cardiac death due to VT or VFib. In fact, it is the most common cause for sudden cardiac death in young individuals and athletes. This is the most common cause for sudden cardiac death. So if I have to suspect or diagnose it, for diagnosis, our investigation of choice is going to be echo. And what are the findings we are going to get in the echo? 3 findings. The first one, you will have concentric LVH, and because the muscle mass is high, the ejection fraction may be high, more than 70% you may get. Okay, apart from that, you will be able to see that there is asymmetric septal hypertrophy, and now that interventricular septum is highly muscular, the papillary muscle attached to it will also be strong and muscular. So during the systole, this papillary muscle may pull the mitral valve, especially anterior mitral valve, forcefully. We call that as systolic anterior motion of mitral leaflet, or SAM. Systolic anterior motion of mitral leaflet, or SAM. And because of this asymmetric septal hypertrophy and concentric LVH, you may end up LV looking like a banana shaped. You may have a banana shaped LV. Very, very important point, because umpty number of times they are asking questions related to hypertrophic cardiomyopathy. Almost every alternate exam there is one question, right? What are the key points to remember? Echo findings. Single most important point, echo findings. Concentric LVH, high EF, asymmetric septal hypertrophy, systolic anterior motion, banana shaped LV. Last exam there was an image based question of a banana shaped LV, easy to recognize. Okay, now if I have to manage, right, if I have to management of hypertrophic cardiomyopathy, so there are many challenges here. The first one is we have to decrease sudden cardiac death risk. So how can I decrease? I can use beta blockers that block the sympathetic nervous system, which is known to trigger sudden cardiac death is due to VT-VF. The trigger is sympathetic nervous system, that can be blocked. Or you can consider implanting ICD, so that if an arrhythmia happens, it is shocked. Okay. Then next, To decrease sudden cardiac death risk, we are using beta blockers, and to decrease HOCM symptoms, obstruction symptoms, what I should do to decrease the obstruction symptoms, one of the thing you can do is you can ablate this septum, interventricular septum, which is asymmetrically hypertrophied. If I cut this out, the obstruction will be relieved. So that can be cut out by surgical, that is called as surgical myomectomy. But if the patient is not willing for major surgery, then you can also inject alcohol into it, and alcohol will cause atrophy. So either you can go for surgical myomectomy or alcoholic septal ablation. Septal ablation. Okay. Another important point I want you to remember, because this is a close differential diagnosis for the aortic stenosis. It is subvalvular aortic stenosis. It's a close differential diagnosis for AS. Symptoms are very similar. How do you differentiate? In AS alone, you will not get pulsus disvariance. In case of hypertrophic cardiomyopathy, you may get pulsus disvariance, 2 systolic peaks. Second, the murmur of AS increases in any maneuver that increases the venous return and decreases if maneuver decreases the venous return. HOCM, remember, acts as an exception. So here, any maneuver that increases the venous return will decrease the murmur, and any maneuver that increases the decreases the venous return will increase the murmur. Right? So remember those points. Now that's about the cardiomyopathies. Right? Now let us talk about valvular heart diseases next. Valvular heart diseases. Now you already know how to approach a valvular heart disease. I have done an elaborate discussion during the offline classes. Anytime there is a clinical question on valvular heart disease, first thing you should see is whether it is a right heart disease or left heart disease, and symptoms will tell you. If it is left heart disease, the congestion is in the lungs, so you will have what? You will have the dyspnea, orthopnea, PND, those symptoms. If it is right heart disease, raised GVP, hepatomegaly, ascites, pulmonary. Right? After that, you will look at the murmur details, from which area that murmur is heard best, and what is the nature of murmur. Is it systolic, diastolic, early, mid, late, and then you will have the diagnosis, right? So the same points I will reiterate again. So when we are talking about valvular heart diseases, if it is a right heart disease, what symptoms we are expecting? If it is a right heart disease, we are expecting raised JVP, ascites, hepatomegaly, and edema. And apart from that, because right side of the heart gets more blood during inspiration, the murmurs on the right side increase on inspiration. Murmurs of the right side of the heart increase on inspiration, right? And this phenomenon, especially when applied to tricuspid regurgitation, is also called as de Carvalho sign. It's also called as de Carvalho sign, especially when we are talking about tricuspid regurgitation. If it is a valvular heart disease affecting the left side of the heart, that is aortic valve or mitral valve, in that case, what symptoms we are going to get? We are going to get dyspnea. You may have orthopnea and PND. In some patients of left heart disease, if the stroke volume is low, like in aortic stenosis, you may have syncope. If stroke volume is not low, you may not have syncope. Okay, this is basic thing that I want you to remember. Dyspnea, think of left. Raised JVP, ascites, hepatomegaly, think of right. Okay, then let us quickly make a list of all the valvular heart diseases. So if you are talking about aortic stenosis on the left, the most common cause for aortic stenosis is, overall most common cause is age-related degeneration. Age-related degeneration. Atherosclerosis leads to calcification. Calcification leads to stenosis. But in young individuals, it is due to congenital bicuspid aortic valve. And the most common mutation responsible for this congenital bicuspid aortic valve is mutation in Notch1 gene. Okay. Now these are causes for aortic stenosis. What clinical features a patient of aortic stenosis present with? It is a left heart disease, and because it is left heart disease, yes, they will have syncope, they will have dyspnea, and because aortic valve opening is narrow, the stroke volume will be less, so they may have less perfusion of the brain, so they may get syncope. And because there is increased afterload, there will be concentric LVH that results in increased myocardial oxygen demand that may not be met by the decreased coronary flow, so you can get the angina. So you have this classical ASD symptoms. So you can get angina, syncope, and dyspnea. Angina is the earliest symptom and dyspnea is a late symptom. And because dyspnea is a late symptom, right, presence of dyspnea is considered as severe aortic stenosis, which is suggestive of severe aortic stenosis. And you also know that there is an expected life expectancy based on the presence of symptoms. So if patient has already developed angina, the expected life expectancy is around 5 years. If he has started developing syncope, 3 years. And if he has started developing angina, it is usually 2 years. So anyone with symptoms is having high risk of death. Okay, apart from that, these patients can develop a triad where the aortic stenosis has resulted in calcific aortic stenosis, particularly calcified aortic valve has resulted in damage to the von Willebrand factor, so they have developed acquired von Willebrand disease. And these patients now, because they have acquired von Willebrand disease, they will also maybe having AV malformations in the GIT from where they start bleeding. So GIT, bleed. Combined with this, what is this triad called as? And we call this syndrome as Hayday syndrome. So they may ask you what are the components of Hayday syndrome. You should be able to answer this. Okay. Now that we know the clinical features, let us quickly talk about the examination findings. On examination, what are we going to get? On examination, in terms of pulse, if it is mild to moderate AS, in pulse, what are we going to get? We will get what we call as anacrotic pulse. Anacrotic pulse. But if it is severe AS, what do we get? We get pulsus parvus et tardus. Pulsus parvus et tardus. Okay. Apart from that, when it comes to auscultation, what are we getting? We are getting a murmur because blood moves from left ventricle to aorta during systole, and that too the movement starts after the isovolumetric contraction. We get a murmur beginning after isovolumetric contraction. So first we will have isovolumetric contraction, and then this aortic valve opens. Opening produces a sound which we call it as ejection click. Ejection click. After that, the blood starts moving from the LV to aorta, initially with increasing velocity during what we call as the rapid ejection phase, and then with decreasing velocity during the slow ejection phase. So we get a murmur which is diamond shaped, which can also be called as crescendo decrescendo murmur, and with that we will have the end of systole, end of ejection, and we will have S2. So the sound we are getting here is called as an ejection systolic murmur or a mid systolic murmur, which is best described as crescendo decrescendo murmur. And where is it best heard? Of course, the aortic area. Where is the aortic area? Right second intercostal space. And where is it best heard? During which phase of cardiac cycle? During which phase of respiration? Remember, left gets more blood during expiration, so louder murmurs. So it is best heard in expiration. We ask the patient to hold the breath in expiration. That is where we get the murmur clear. If we had HOCM as the cause for subvalvular aortic stenosis, okay, let me just write down these points that I want you to know to differentiate between HOCM and this murmur. So this murmur increases on inspiration, increases on expiration, and apart from that, this murmur increases on any maneuver that increases the venous return, and the murmur decreases on any maneuver if the venous return is decreased. So we have to make a note here. If HOCM, we get a similar systolic murmur. We get a similar systolic murmur, but that murmur decreases if there is increase in venous return, or increases if there is decrease in venous return, right? Remember this particular point. And also HOCM will have pulsus bisferens. Here we will have pulsus parvus et tardus. So once we have suspected based on the clinical findings, for diagnosis, the investigation of choice is going to be echocardiography. So when it comes to diagnosis of AS, diagnosis will be, the investigation of choice is echo. And remember, whenever you have the aortic valve area less than 1 centimeter square, right, we call it as severe aortic stenosis. Now when it comes to the management, the definitive management is aortic valve replacement, aortic valve replacement. And for patients who are unfit for open heart surgery, we can replace the aortic valve with a procedure called as TAVI or TAVR. Okay. Now in the workbook you have the indications. Please go through that, solve some MCQ so that you remember it. How do you choose whether I should go ahead with aortic valve replacement or not? If it is a symptomatic patient, you know that life expectancy is less, you have to go ahead with aortic valve replacement. But if it is asymptomatic, some of them may be pseudo asymptomatic, we want to unmask them, so we make them run on a treadmill. If that comes up abnormal, that is a pseudo asymptomatic patient, we have to go ahead with aortic valve replacement. But if the TMT is also normal, these are true asymptomatic patients. In them we can wait, we can do conservative management, but you might have to consider the valve replacement if EF is low, or if it is severe AS patient going for other cardiac surgeries. So this protocol is something that I want you to remember. I'm anticipating a question on this time. Okay, so that's about our aortic stenosis. Then definitely you're also expected to know about aortic regurgitation. I will only discuss the key points that you should not miss. So when it comes to the aortic regurgitation, the causes for aortic regurgitation, as you remember, will be classified into the valve causes and root causes. So aortic regurgitation, it can be acute or chronic. I'm not going to get into the details of acute. Most important is chronic, right? So let me concentrate on chronic. You can revise the acute from the workbook. So when we're talking about the AR, the causes for AR can be classified into valve causes and root causes. The most common root cause that causes AR is hypertension. The valve causes could be bicuspid aortic valve. Okay. Now when I have AR, what all clinical features we are going to expect? Remember, AR simply you should think of increased stroke volume but decreased diastolic BP. AR is equal to increased stroke volume, decreased diastolic BP. And because of this increased stroke volume, you will have increase in systolic BP and you will have decrease in diastolic BP, making you have wide pulse pressure. So what this wide pulse pressure leads to? Wide pulse pressure leads to a pulse which is called as collapsing pulse or Corrigan's pulse. Collapsing pulse or Corrigan's pulse, also called as water hammer pulse. Okay. Apart from that, it makes visible pulsations. Pulsations become visible. We call them as peripheral signs of AR. We call them as peripheral signs of AR. Okay. Apart from that, another thing is, in case of the aortic regurgitation, we have discussed this pathophysiology behind it. There is increase in the stroke volume because of the dilatation and eccentric LVH, the EF increases. So these patients have eccentric left ventricular hypertrophy as well as LV dilatation, and because of that they get what we call as cor bovinum. The maximum possible size of the left ventricle is seen in patients with AR, and it also leads to the increase in EF. That increase EF results in increase in stroke volume. That's why we are getting high systolic BP. Now, when these patients come to us and when we examine, because these patients have massive left ventricle and it is forcefully contracting, they may have palpitations as a symptom. Apart from that, it is a left heart disease. So in terms of symptoms, yes, they will have dyspnea as a symptom. So in terms of clinical features, they can develop dyspnea, but dyspnea is again a late symptom, and because it is a late symptom, presence of dyspnea is suggestive of severe AR. Severe AR. Okay. Apart from that, in terms of clinical features, most of the symptoms are related to peripheral signs of AR only. And what are these peripheral signs of AR? We have had a long named list of peripheral signs of AR. Let me just quickly take you through those named peripheral signs of AR. One we have is De-Musset sign, where patient will have head bobbing. Lighthouse sign, where there is alternating flushing and pallor of the forehead. Then Corrigan sign. Corrigan pulse is water hammer pulse, collapsing pulse. Corrigan sign is dancing carotids. Then we have locomotor brachialis, visible brachial artery pulsation. We have Quincke sign, visible nail bed pulsations. Pistol shot femoralis, the booming sounds heard over the femoral artery in systole. Duroge's murmur, murmur heard over femoral artery. And Hill sign. Normally, systolic BP in the lower limb is higher than the systolic BP of the upper limb by up to 20 millimeters of mercury. If the gap becomes more than 20 millimeters mercury, we call it as Hill sign. These are all peripheral signs of AR. And when you have peripheral signs of AR, it means you have wide pulse pressure. You can get these peripheral signs of AR in any other condition where there is wide pulse pressure, right? So I'm leaving these peripheral signs of AR for your revision here in the notes. Okay, so now if it is a case of AR, investigation of choice is going to be 2D echo, and we will call it as severe. See, remember, we call it as severe AS when the aortic valve area was less than 1 centimeter square. For AS, for AR, we can't measure the opening size. Opening size gets narrowed in stenosis. In regurgitation, valve fails to close. So you have to measure how much volume is regurgitating. And if the volume that is regurgitating is more than or equal to 60 ml, we will call it as severe. We will call it a severe AR. The investigation of choice for all valvular heart disease will be echocardiography. So we will do an echocardiography, and if I see that the regurgitant volume is more than or equal to 60 ml, it is a case of severe AR. Now, when it comes to the management of AR, you have to remember one extra point. What is the point I want you to remember? When we're talking about AR management, nitrates have a disease modifying role. Why? Because in AR, the eccentric left ventricular hypertrophy that is happening, it is because the ventricle is handling more blood. More blood is regurgitating back to the ventricle, adding to the end diastolic volume. To eject that, ventricle has to do more work. End diastolic volume means preload. Increased preload means ventricle develops eccentric hypertrophy. But if I peripherally dilate the blood vessels, more blood flows towards the periphery, less regurgitates back, so reduces the burden on the left ventricle. So it has a it facilitates the forward flow, and thus they have disease modifying properties. So you can start them on the nitrates to halt the disease progression, and if still it progresses, then definitive treatment is going to be aortic valve replacement. Definitive treatment is aortic valve replacement, but you should also note that nitrates have disease modifying property when it comes to a case of aortic valve regurgitation. Okay. So that completes our discussion on the AR. Now I'm leaving behind an extra part for you to spend half an hour, because I want you to spend half an hour every month till your exam on this particular part, which is the markers of severity of valvular heart disease. When you say aortic stenosis as severe, when you say aortic regurgitation as severe, when you say mitral stenosis as severe, and when you say mitral regurgitation as severe. Okay, so please go through that from the workbook. Now, after the aortic regurgitation, let us talk about mitral stenosis and mitral regurgitation. So when we talk about, I forgot to mention the murmur itself. So what murmur we are getting apart from these peripheral signs of AR? We are going to get a murmur which is early diastolic murmur. So the murmur in AR is going to be early diastolic murmur. So it exactly starts in the isovolumetric relaxation phase, may continue a little into passive filling and barely ever into active filling. So it is a early diastolic decrescendo murmur. Early diastolic decrescendo murmur. Where is it best heard? It's left sided, so it is best heard in expiration. And which area? It can be heard in the aortic area, which is right second intercostal space, but the best heard in Erb's area. What is Erb's area? The right third intercostal space. So if they are asking what you should prefer, Erb's area should be preferred over aortic area. Erb's area should be preferred over the normal aortic area. Erb's area is also called as neo-aortic area, if you remember it. Erb's area will be preferred over aortic area. Okay, clear? Now in terms of severity, because we are talking about it, let me tell you the duration of murmur is a marker of severity. In case of aortic stenosis, what is the marker of severity in terms of murmur? Click to the peak duration. It is the marker of severity in AS. In case of AR, it is the duration of murmur. In case of mitral stenosis, it has an inverse relationship. Means the second heart sound to the opening snap gap. Shorter it is, more severe is the mitral stenosis, right? So next up, we are going to talk about the mitral stenosis. And when we talk about mitral stenosis, remember the most common cause for mitral stenosis is what? Rheumatic heart disease. Don't have to bother about other cases. Now what happens in mitral stenosis? In mitral stenosis, in terms of clinical features, because the transfer of blood from left atrium to left ventricle is impaired, the left ventricular filling is less. So because of that, because of decreased LV filling, you will have decreased stroke volume that will result in syncope and fatigue as the symptoms. Apart from syncope and fatigue as a symptom, there will be increase in left atrial pressure. Increased left atrial pressure will lead to, like, as you know, there will be a domino effect and every chamber will keep dilating. So there will be dilated left atrium. Eventually there will be increase in pulmonary vein pressure, and that will also lead to dilatation of the pulmonary vein, and eventually it will lead to pulmonary congestion, as you know. And once there is congestion, what symptom are we expecting? This will lead to development of dyspnea. So you can have syncope and dyspnea. You had the same symptoms in patients with aortic stenosis as well. The point to note here is this left ventricle which is dilated, left atrium which is dilated, can cause compression of left recurrent laryngeal nerve, and that can lead to hoarseness of voice, and we call it as Ortner's syndrome. So you may get Ortner syndrome in mitral stenosis. These are the important clinical features you need to remember. Also in the workbook, you have a mitral facies picture. Low cardiac output leads to cyanosis and facial plethora. We call it as mitral facies. So these are the symptoms we are expecting. Okay. Now, if I have mitral stenosis, when it comes to investigation of a case of mitral stenosis, they may ask you a little more than aortic valve. So if you do ECG, you will see that there is left atrial enlargement and it is visible as P mitral. You will have what we call as bifid P waves. You will have a bifid P wave, P mitral as you call it as. It's called as P mitral, bifid P waves. Then the X-ray also shows left atrial enlargement in the form of straight left heart border and double right heart border. Double right heart border. Echo is the investigation of choice. Echo is the investigation of the choice, and I definitely want you to go through this table of severity classification. So to call it as severe mitral stenosis, the mean gradient, The gradient is defined as mean left atrial pressure minus mean left ventricular pressure during diastole should be more than 10 millimeters of mercury, mitral valve orifice less than 1 centimeter square, pulmonary artery systolic pressure more than 50 millimeters of mercury. And if the gradient is more than 15 millimeters of mercury, that will be called as very severe mitral stenosis, right? So you please remember this table, important for you. Okay, now that we know the mitral stenosis causes, basic clinical features, we will also look at examination findings. I forgot to mention that on investigation, yes, these are the findings we are going to get. On examination, what murmur I'm going to get? I'm going to get a mid-diastolic murmur with pre-systolic accentuation. So the murmur begins after isovolumetric relaxation when the mitral valve opens. It's a stiff valve, so opening produces a noise. We call it as opening snap. And after that, the blood starts moving from the left atrium to left ventricle, first through passive filling and then eventually through active filling. And during this period, the movement of the blood in the passive filling produces a murmur. This murmur intensity increases in the active filling, right? Increase in the active filling. So this murmur is described as mid-diastolic murmur. Usually we use the term rumble because it's a very faint sound. Mid-diastolic murmur with pre-systolic accentuation. Pre-systolic accentuation. Murmur increases during active filling because atria is contracting more forcefully during the active filling to push the blood through this narrow opening. Pre-systolic accentuation. And the key point to note here is, when is this pre-systolic accentuation lost? Pre-systolic accentuation lost or absent. You can better write it as absent. Absent if patient develops AFib. In patients with atrial fibrillation, this pre-systolic accentuation that we are getting will be absent. Okay. Now that we know mitral stenosis and basic diagnosis, let us look at its management. When it comes to its management, because most common cause is the rheumatic heart disease, these patients may require penicillin prophylaxis depending on the age. And apart from that, the definitive management here, because it is rheumatic heart disease where there is commissural fusion, we can try to open that commissures using balloon mitral valvotomy. Balloon mitral valvotomy is the definitive treatment. Right? When is it indicated is a question. So in the workbook you have the protocol. When is it indicated? The balloon mitral valvotomy is indicated in patients with mitral stenosis if they are having symptom. Main symptom is dyspnea. If they're symptomatic and the mitral valve orifice area is less than 1.5 centimeters square. If the orifice area is more than 1.5 centimeters square, then probably MS is not the reason for symptoms. So we will manage conservatively. And if they're asymptomatic and it is not very severe, conservative management. But if it is asymptomatic and very severe, what is very severe? With a gradient more than 15 millimeters of mercury, we will go ahead with the balloon mitral valvotomy. So these are the indications for balloon mitral valvotomy. So they may also ask you, when is the balloon mitral valvotomy contraindicated? It is contraindicated if there is a left atrial clot, or patient already has moderate MR, or there is calcified valve or the commissure. Where LA clot is considered as a relative contraindication, because if you do 3 weeks of anticoagulation, this clot will disappear and then you can do balloon mitral valvotomy. But other conditions are absolute contraindication, where you have to go for the mitral valve replacement. Okay. In terms of markers of severity, these are what we are expecting. Dyspnea, loud P2 or palpable P2. Dyspnea is, of course, always a late symptom. So late symptom is severe. Loud P2 or palpable P2 because it indicates that patient has developed pulmonary hypertension. Then parasternal heave, that means the problem of left has reached right, and right ventricle has developed concentric RVH, and that's why its force of contraction we are able to feel. Raised JVP again suggestive of right heart failure. And in terms of murmur, severity of MS inversely correlates with the second heart sound and opening snap gap. This gap, lesser it is, more severe is the mitral stenosis, right? So these are the markers of severity that I want you to remember. So similarly, we have the markers of severity for aortic stenosis and aortic regurgitation that I want you to remember, because these are the tables according to me that you need to by heart. You need to by heart. There is no escape from that at all, especially this point here. The severity has inverse correlationship with the second heart sound and opening snap gap. Okay, clear? So let me just copy paste the markers of severity of aortic valve diseases as well, so that our prep is complete for basic valvular heart diseases. Let me add a page here. Markers of severity of AS, markers of severity of AR. I want you to by heart them because they are very, very important. 1 mark is literally hidden in these tables. Okay, so last topic we're going to talk is going to be mitral regurgitation. Mitral regurgitation. MR can be just like AR, can be acute or chronic. We will mainly concentrate on chronic because that is where we are expecting majority of the questions to come from. And when we are talking about the mitral regurgitation, the causes can further be classified as the valve causes and the LV causes. LV causes are called as secondary or functional MR, where left ventricular dilatation is the reason. And if the problem is in the valve itself, we can have valvular diseases. So RHD, rupture of chordae, dysfunction of papillary muscles, carcinoid, and mitral valve prolapse, these are all valvular causes. Dilated cardiomyopathy, IHD, and aortic regurgitation is where LV dilates. So these are LV causes or secondary or functional MR causes. Particularly, I want you to pay attention to mitral valve prolapse, which is also known as floppy mitral valve syndrome or Barlow syndrome, where there is myxomatous degeneration of the mitral valve. Right? This is typically more common in females, and the most common presentation is palpitation. So if there's a question talking about young female with palpitation, and they specifically mention that there is a systolic click heard, it is always talking about, or it is pointing towards mitral valve prolapse. Clear? So when we are talking about MR, we can have valve causes and LV dilatation related causes. When it comes to LV dilatation related causes, you have to remember the dilated cardiomyopathy and ischemic heart disease and aortic regurgitation. When it comes to valve causes, I want you to remember RHD. We're right now only talking about chronic, so let us not bother about the papillary muscle dysfunction and chordae rupture, which causes acute MR. Another thing is mitral valve prolapse. Mitral valve prolapse, please remember, think about young female plus systolic click plus palpitations. Okay, and this murmur of mitral valve prolapse causing MR behaves as an exception to the basic rules. Normally, increased venous return, murmur increases, decreased venous return, murmur decreases. But if it is due to MVP, it behaves as an exception. Remember that rules we have written. HOCM and mitral valve prolapse behave as exception, right? Okay. Now, these patients, what clinical features they will present with? So, even in patients with mitral regurgitation, there is increase in left atrial pressure because of the regurgitation. The pressure in the left atrium increases. So that will cause compensatory dilatation, pulmonary congestion, dyspnea. Dyspnea is always a late symptom, so it is considered as a severe M. Then there will be increase in end diastolic volume because the regurgitant volume that has gone to the left atrium comes back to the left ventricle, increasing the end diastolic volume. And that high end diastolic volume means increased preload, and whenever there is increased preload, we develop eccentric LVH. And whenever eccentric LVH or LVH, muscle mass increase means ejection fraction increase, and combined high end diastolic volume plus high ejection fraction, we will get high stroke volume and high systolic BP. And eccentric LVH contraction may be felt by the patient as palpitations. So these are the symptoms we are expecting. We are expecting dyspnea, and dyspnea is always a late symptom, and whenever there is a late symptom, it is always suggestive of severe MR. Okay. Apart from that, this eccentric LVH contraction may be felt by the patient as palpitations. That is another symptom that we can expect. Now, when we examine, these patients will have a murmur, and that murmur is going to be pansystolic. Remember, acute MR causes early systolic, but in case of chronic MR, it is going to be pansystolic murmur. Why is it going to be pansystolic murmur? Because in chronic MR, the pathophysiological changes include hypertrophy of LV and dilatation of LA. So LA can receive a lot of blood. LV being muscular, it can keep giving the blood. So throughout the systole, the blood keeps regurgitating. That's why we get pansystolic murmur. So chronic MR classically produces a pansystolic murmur. And where is it best heard? So pansystolic murmur best heard in the mitral area, which is apex. And apex here is displaced, remember that. Because there is eccentric LVH and dilatation of the left ventricle, it is displaced. And because it's a left heart disease, the murmur will be best heard in expiration. Okay, clear? Now, if I have MR, what is going to be my management? So when it comes to the management of mitral regurgitation, the point to note is, just like how the nitrates had disease modifying property in case of the aortic regurgitation, beta blockers can have disease modifying property, because beta blockers reduce the volume of blood that can get regurgitated to the left atrium. How will they reduce? Because they will decrease the force of contraction, so less blood regurgitates into the left atrium. So if less regurgitates, less blood comes back, so less work that ventricle needs to do. So ventricle will not develop so much hypertrophy. So it slows down or halts the disease progression. So beta blockers are considered as disease modifying agents. Beta blockers for a patient with MR have disease modifying properties. Apart from that, yes, the definitive treatment for, just like any other valvular heart disease, is going to be mitral valve replacement. Okay. Now, what can be considered as the markers of severity in case of mitral regurgitation? So it is there in your workbook, a long list of markers of severity. This is something that I want you to by heart. Okay. So that completes our valvular heart disease discussion. Now, from the template, you have an idea. How do I recognize whether it is a right heart disease or a left heart disease? That is pretty simple. If it is a right heart disease, the main symptoms are going to be the right-sided symptoms, that is raised JVP, hepatomegaly, ascites, pedal edema, and you may have a similar murmur. AS murmur and PS murmur are same, but the symptoms of PS will be right-sided symptoms, and the murmur will be heard in the pulmonic area. AR murmur and PR murmur are same, but the symptoms of PR will be right-sided symptoms, and the murmur will be best heard in pulmonic area instead of the herbs area. If it is MS murmur, it will be similar to the TS. Both are mid-diastolic with pre-systolic accentuation and opening snap. But the TS murmur will be best heard in the tricuspid area. MS murmur will be heard in mitral area. MR and TR are same. They are both pansystolic, but MR murmur will be best heard in the mitral area, which is apex, and the TR murmur will be best heard in the tricuspid area. So the area and symptoms will always take you to the diagnosis, right? So that completes a quick review of important cardiology topics. The ischemic heart disease, I want you to go through the detailed discussion through the main notes, and also the rheumatic heart disease, especially the rheumatic fever, especially the diagnostic criteria. These are frequently asked MCQs, so don't miss out on them. Quickly glance through before you give the day after tomorrow's subject-wise test. And please don't stop solving MCQs from any subject, including medicine, till your last day, right? So I'm signing off from the cardio modules. You will also have a rapid revision video for the respiratory system, which will be available right after this.